Thank you so much. Thank you. And as you mentioned, we will have Yevhen joining on video. So in between me and Maria speaking, we will have Yevhen making some comments about, for instance, the situation in Ukraine. But Maria, do you want to start with talking about Swecare Preparedness?
I can start. Thank you very much, and thanks for the opportunity to be here. My name is Maria Helling. I'm the CEO of Swecare Foundation, and that is an organization. Let me see if I can use that one.
I think we have this. Okay. Yeah.
You think I'll do that?
Yeah.
Yeah. It's an organization that was founded by the government, by the Swedish regions and the private sector in the 70s with the aim to support internationalization of the Swedish healthcare sector and also contribute to better health around the world. 2 years back, we have a specific government assignment to support Ukraine and support the Ukrainian healthcare system, mainly through creating partnerships between Swedish and Ukrainian stakeholders. And within this project, we have received quite many Ukrainian delegations to Sweden. We have created different kind of virtual meeting places, seminars and webinars, and also 2 major conferences. And we have worked within different areas, prosthetics being one, digitalization, infection prevention and antibiotic resistance, and oncology. But one area that we find, I think I just clicked it. Oh, yeah. One area that we find extremely interesting and that we are developing at the moment is the area of health emergency preparedness. And when talking about healthcare in crisis, our attention is naturally drawn to the front lines, to trauma care, to emergency surgery and injuries of war, of course. But as you might have discussed a lot here today already, I think we all know that that's not where most people die. Most illness and death come from the same causes as they do during peacetime, of course. So we have the chronic diseases, interrupted treatment, lack of access to basic care, the ordinary health needs that don't disappear just because we have a crisis. They might be harder or even impossible to meet, though. And that is, of course, why primary care becomes critical. So if the primary care system collapses, it's not only a health issue, it's a much broader societal issue. It's very hard to keep a country resilient, and it's hard to have a willingness to fight if people do not know that their children, their parents, vulnerable people in society receive the care and support that they deserve. So a trust in this system is fundamental. And from our side, from Swecare, what we would like to understand better is how primary care can remain functional even under extreme pressure. What does preparedness look like in practice, and how can we strengthen systems so they do not just respond to crises, but withstand them? This is something we have discussed, and when Yevhen Prylypko, who we will talk to, or we will listen to later on, reached out to us, and he represents an organization with a very long name, All Ukrainian Association of Amalgamated Territorial Communities. I think that's an association of regions and municipalities in Ukraine. Yeah, they reached out to us and they wanted to explore Sweden's rural healthcare experience. And we saw that then as an opportunity for us as well to learn. So together with SALA International, SQR International that you might know of, and the Centre for Rural Health, we decided to facilitate an exchange. So we organized this incoming delegation. They visited different places in the north of Sweden, Norrland University Hospital, Lycksele Hospital, Vilhelmina sjukstuga, some other places. Yes. And it was described as something very successful. In December last year, we arranged also a bigger conference where they participated and formalized this partnership in a letter of intent, something like that. So from Swecare's side, we find this super interesting. We will continue to support it. We believe that there's a great benefit, of course, for Ukraine, but also that we can learn a lot from it. So we're very happy for this opportunity. And I think I'll stop there, Andreas, and let you Or Yevhen, maybe
I think we'll
talk a
start
little
with
bit.
Yevhen. And let's now hope that the technology gods are with us. Let's see.
Dear colleagues, it is an honor for me to speak to you today on behalf of Ukraine. Within our collaboration with Swecare, Salar International, and the Swedish Rural Health Centre. Our partnership began in 2025 with a study visit by a Ukrainian team as part of the Swedish Community Hospital Study Tour. This created a foundation for dialogue and joint solutions. In this context, I would like to briefly share Ukraine's experience, especially how primary healthcare works today in the conditions of war. Ukraine's healthcare system has been undergoing deep transformation since 2015. Through decentralization, hundreds of healthcare facilities were transferred to local communities, along with responsibility for primary care. This brought autonomy, but also fragmentation and uneven capacity. Before the war, the system was often criticized for too many small facilities, uneven quality, and limited funding. But during the war, these features became a strength. Because the network was not reduced and care remained close to people, supported by local autonomy, the system did not collapse. When roads were destroyed, territories occupied, and logistics disrupted, local primary care doctors, and often any healthcare worker with medical training, became the only accessible point of care. Clinics in villages and small towns turned into centers for emergency support, chronic care, psychological help, and evacuation coordination. Small facilities adapted quickly. Teams changed roles, shared resources, and responded immediately to local needs. This is a key lesson. Resilience came not from perfect design, but from flexibility, proximity, and local trust. At the same time, challenges have only deepened, especially in rural areas due to migration and depopulation. The workforce is aging. According to our latest study of primary healthcare providers, over 42% of primary care staff are already aged 60 plus, rising to 70% in some facilities, while among more than 1,200 medical workers, there are only 33 interns potentially available to replace them. Funding remains insufficient. Primary care receives no more than 13% of total health financing, while the needs for specialized medical care are increasing in wartime conditions, with growing demands and many tasks remaining undercompensated. Infrastructure and logistics are also weak. Poor roads, limited access to regular public transport services, and a shortage of male drivers due to wartime conditions mean many patients, especially elderly people, cannot reach care without support. There is also strong emotional pressure. Continuous stress and loss lead to burnout and staff leaving the system. Digital tools were expected to help, and Ukraine has a strong but very complex and constantly evolving eHealth system. However, technology alone is not enough. With an aging and exhausted workforce in rural areas, adopting new tools is difficult. Without incentives, training, and simple solutions, many technologies remain underused, and basic communication often works better than complex systems. So today the question is not only about rebuilding, but about rethinking how to support primary care, especially in rural areas. Ukraine's experience shows that even a fragmented system can be resilient if it is close to people, flexible, and locally supported. But to sustain it, we must invest in people, motivation, practical solutions, and introduce new models of organization and management. Thank you, and I look forward to continuing this dialogue together.
Thank you, Yevhen, for setting the scene. And I will continue now with, let's see if it works, yes. I'll take a few minutes to talk to you about what we do at the Swedish Centre for Rural Health. My name is Andreas Lundqvist, as has been mentioned, and I'm the head of unit. I've been working at the Swedish Centre for Rural Health since 2014, and I'm the manager since 2020. We were also established in 2014, and we solely work with research, development, and innovation. We don't deliver healthcare, might be stressed here. Since our establishment, we have expanded quite a lot, and now we are more than 20 employees actually working with research, but also, as I said, innovation and education. This illustration shows both our entire line of work, actually, but also the environment in which we operate, the rural and sparsely populated areas in Sweden, in the region. And we work with research, education, and innovation around how to provide good, close, and equal healthcare in rural and sparsely populated areas. So it can be described as our work revolves around generating more knowledge about the individual's needs and perspective, the individuals who lives in these areas, Sami health, our indigenous people, but also competence provision, as Yevhen mentioned, it's really important also in their setting, as well as digitalization and eHealth, and everything connected to our context, to the specific conditions, needs, challenges, and opportunities that we have. And speaking about the conditions, a few words about the geography. I guess most of you here are Swedish, some of you aren't perhaps, and this is a map of Västerbotten. We are located in the small rural town of Storuman, our center. The county of Västerbotten is the second largest in Sweden, but only about 280,000 people live there, and most of them live by the coast. This means that the inland parts and the mountainous parts are very sparsely populated. And we have some common challenges in the area. As I mentioned, we are very sparsely populated. We also have an elderly population, and what that implies when it comes to healthcare needs. And we also have long distances to almost everything. So the big idea or the continuous question that we are working with is how can we bring healthcare as close as possible to our rural population? One way of addressing this is by strengthening primary care. And we do so through what we call the cottage hospital model. There are 7 of those spread around the area. And as you can see in this list, they do more than you would normally see in primary care, at least when it comes to Swedish primary care. They have a very good and close collaboration with the nearest hospital in Lycksele, located in the very center of the county. Axel talked about integrated care, and the cottage hospitals are also a very good example of integrated care, as the wards are a cooperation between the municipalities and the region. They also represent a kind of distributed healthcare covering a large geographical area. And this, of course, has implications when it comes to preparedness, which I will get back to later on. Last year, we were giving a national assignment to spread knowledge about the condition challenges and opportunities for health and medical care in rural and sparsely populated areas for all of Sweden. This means that we will continue to work with both research and development. We will continue with our educational initiatives. We want to deepen our collaboration with our 3 closest universities, Umeå, Luleå, and Mid-Sweden University. And we are looking into a possible establishment of nodes throughout the country. We actually have a meeting tomorrow with this region, Västra Götalands region. We are also well into the process of becoming a WHO collaborating center on rural health, not surprisingly. And we are already collaborating quite a lot with WHO. We are, as of October 2022, a demonstration platform for primary care in rural areas. Being a demonstration platform means that we receive visits from countries in Europe that want to develop their primary care and has perhaps a special interest in rural healthcare. And the visits includes workshops, deep dives into specific topics, policy dialogues, connecting national and regional decision makers and practitioners from the host and visiting countries. Coming into Ukraine. Last year, we had the pleasure of welcoming this Ukrainian delegation that Maria talked about. A trip to Västerbotten, which we co-organized with Swecare and Salar International. We were happy to do so. And I would now like to show you a video of that trip that one of Maria's co-workers has put together. Let's see if the technology gods are still with us.
втілення того образу сімейної медицини, ну, можливо, не бездоганної. Я побачив деякі речі, які тут варто було би зробити по-іншому, на мою думку. Вони зробили по-своєму і в тому праві. Але вони чітко показали, що сімейний лікар, лікар загальної практики, здатен робити значно більше, ніж він робить у нас в Україні. Медсестра достойна значно більшої поваги і значно більшого місця в системі медицини. І це пов'язано з тим, що люди, ці шведи, зрозуміли, наскільки важливий пацієнт. Не медицина, не лікарня, навіть не амбулаторія, а саме пацієнт. І в його інтересах зроблено саме так.
Nice to hear that he mentioned patient-centeredness, and he also mentioned the roles for healthcare staff in the Swedish cottage hospital model that he really liked. And I would like to end my part of the presentation just saying that since that visit, we have started working, focusing some of our work towards just preparedness, and especially preparedness in primary care. We held an event in Stockholm in January this year where we gathered local, regional and national decision makers and key people. We had the pleasure of having Emma as a guest there in that discussion. And we are now working on establishing some kind of national primary care preparedness center together with other regions throughout Sweden. And of course, we want to incorporate the expertise from our Ukrainian partners into this. What we have seen is, of course, that primary care will have a crucial role in case of a crisis or, in worst case, war. We see that even small improvements in competence, in quality, can greatly enhance preparedness, resilience, and accessibility in healthcare. And as I touched upon earlier, we believe that the cottage hospital model is a good way of ensuring that the healthcare capabilities stay in an area and that it can't be taken out with just a single bomb. So we would like to end our presentation with some further reflections from Yevhen about our future collaboration.
Today, I would like to focus on how cooperation with Sweden, and especially with the Swedish Centre for Rural Health, can help us respond to key challenges and build more resilient primary care in rural areas. The Swedish experience shows that even in very remote areas, it is possible to organize high-quality and accessible care. I had the opportunity to see how small cottage hospitals work in rural Sweden. These are real local health centers where people can receive primary care, emergency support, maternity services, and even some basic surgical care, supported by telemedicine, including remote consultations and simple virtual rooms for monitoring and communication. For us in Ukraine, this is not just an example, but a clear direction for learning and adaptation. Our team is working with Swedish partners to better understand this experience. For example, the Swedish Centre for Rural Health has developed the framework for remote rural workforce stability, which offers practical tools to support medical staff in rural areas. These solutions are important not only to study and adapt, but also to implement in practice in Ukraine, especially in the context of war, demographic crisis, limited financing, and an aging medical workforce. This is where we see real value for cooperation. At the same time, Ukraine also has something to share. During the war, our primary care system showed strong flexibility. Local communities made fast decisions and continued providing care even when territories were isolated or under pressure. This experience is important for understanding resilience in crisis situations. Based on this, we have developed a broad and adaptive program called the Ukraine Community Healthcare Network Assessment and Reconnection of People to Healthcare. It is planned as a pilot project for integrated primary healthcare and community care in the Poltava and Vinnytsia regions, covering around 1.5 million people in rural communities. The goal is to build a model of integrated primary care combining medical and social services in one place, supported by modern technologies and new organizational approaches. It is aligned with the National Health Strategy 2030, and its conceptual framework has already been endorsed by the Ministry of Health of Ukraine. Our team sees a clear role for Swedish partners, technology companies, and financial organizations. Their support can help us move faster and build a system that works for people in rural areas. And this is why today I would like to say very directly, we are waiting for clear and tangible signals of support. Because for us, this is not just a project. It is about access to care, people's lives, and the future of our communities and Ukraine. We are deeply grateful to Sweden and to the Swedish people for the support that Ukraine is receiving. But sometimes, living in a very different rhythm of life and challenges, it may feel to us in Ukraine that decisions are moving too slowly. In Sweden, there is a word Lagom, meaning balanced, moderate, just enough. It is a beautiful concept. But in our reality, every delay means real losses of health and sometimes of life. We live in a different time. In Kyiv, you can hear air raid sirens as well as the sounds of air defense, shots and explosions, even on a sunny spring day. People don't pause for a moment and keep going with their daily routines and work. It may look strange, but this is our reality. We simply know that our time is limited. In 6 days, I will turn 50. And when I look at the average life expectancy for men in Ukraine today, it is around 57 years. This means that I personally have very limited time to make a real impact, to help build a system that will support people, including when I myself will need this support. And this is why Ukrainians may sometimes seem impatient, emotional, even nervous. It is not about character. It is about reality. Because in this uncertainty, sometimes tomorrow or next week, there may be no one left to respond. Speaking here at a digital health conference, I would like to finish with words from Steve Jobs that I first heard when I was 30 in his Stanford commencement speech about 3 life stories, and which today carry a very different meaning for me and for millions of Ukrainians. Your time is limited, so don't waste it living someone else's life. I encourage you to revisit this speech. Today, these words resonate strongly for us in Ukraine and for me personally. Thank you for your attention and your understanding. Slava Ukraini.
Thank you, Yevhen. Very strong words from Yevhen. So that's all for us. Thank you.
We do have time for a few questions or comments. If anyone would like to. No one wants to go first. I'm a bit taken aback because we've been talking about the healthcare system as part of our defense the entire day. We've been trying to sort of get a sense of urgency in the room. But it's hard when you're Swedish.
Yeah.
It's much easier, even if Yevhen is on a film, his words are so much stronger than anything we can ever say. And I'm a bit taken aback by it, because it seems really important that we raise our sense of urgency, both in the collaboration with the Ukraine, but also the sense of urgency in Sweden, what we do to try to increase our preparedness. Do you have any additional reflections on that? How can we, I mean, you've been signing letters and we're creating centers and discussing things. What do we actually do to move forward?
First, I just would like to say that it was very emotional to receive this study visit from Ukraine and to hear that they, even during war, they find the strength and willing to develop their healthcare system. It's it's mind blowing actually that they have that feeling and that mindset to do so. We are working quite hard to try and go forward with our collaboration, but as Yevhen politely mentioned, things in Sweden are a bit more bureaucratic, and we need to abide by laws perhaps that they don't, in some cases, don't have to. And of course, in our case, actually, we need to find funding. That's one of the key factors for us. So in that small sense, if there's some financier sitting in the room, please help
Please
us
send money.
Please send money, absolutely. No, but of course, we want to help Ukraine as much as we possibly can. They have a very big interest in the cottage hospital model and see that as a way of rebuilding their healthcare system, especially perhaps in rural areas, as Yevhen mentioned. And we want to help out in any way possible in that sense. And as Yevhen said, they have a lot to offer us. We want to pick their brains on what they know, not only on preparedness, but they, as he mentioned, they work a lot with digital tools, even more advanced than we do in Sweden. So for sure, we want to continue and deepen our collaboration.
Excellent. And I hope there are some financiers here in the room. Maybe it's questions, maybe it's money. You never know. All right then. That's fine as well.
Thank you very much. I'm Kristina Lundqvist-Montan, working for Maxim and CCO, and we're working with disaster planning, and we are also a partner of Swecare, and we work with the Ukrainians, but we work more in the trauma line, but also now in the primary care organization. So we will have an exercise which is Vega 2.0 in Östersund, in Region Jämtland Härjedalen, in 2 weeks. Do you know about that?
I did not. No,
okay,
no.
because
I'll be joining you.
So good. You're
I'm
so
going.
welcome. No, so we will be facilitating the the evaluation, but also the setup of the exercise, and we will do the 3 next days after the incident. So I think that would be a good way, thinking in the 4S concept and the plus.
Absolutely. Thank you.
Yeah. Excellent. I'm looking forward to it.